All right. 210 it is, and it's my pleasure to introduce Dr. Timothy Carl, who took one of these series not too long ago, and he himself is a faculty now at University of Chicago. And University of Chicago is very well known for its for its education on coagulation. They do a fantabulous job when it comes to teaching their residents as well as their faculty, and their faculty are amazing too. So, Tim, all yours, take it on, and let's see how you can give back to the group that you learned from. So, let's go
Sure
back.
thing. Yeah, I definitely remember taking this course myself 3 years ago, as it were. We had a little watch party in our living room. So technically, we may have been undercutting Chicago Path Society on individual registration fees. Oops, maybe I shouldn't have said that. But no, thanks for having me here. As mentioned, I'm one of the transfusion and coagulation pathologists at the University of Chicago. I work with Drs. Alderweich and Chota, and probably here to reduce the reputation of the program's quality in coag teaching, but we'll do our best. So I'm honored to be teaching as part of this series. We only have 45 minutes assigned to cover about 60 slides, and we'll try not to cut into the break too much. So let's just go ahead and get started. Also for questions, I think this method that people have of putting questions in the chat and then the speaker addressing afterwards, that'll work well for me. So if you have anything, just throw it in chat. If you notice anything egregiously problematic with the presentation, please do interrupt me though. Say, for example, if my slide won't advance. There we go. Now, why even review coag? Reasonable question. If you look at the American Board of Pathology's blueprint, you'll see that hemostasis and thrombosis only get a tiny section, one page within the hematopathology block, frankly, making up only a tenth of a section that you guys get like 2 hours of education on otherwise. This is a little misleading. In my experience, coag is actually fairly well represented on the CP exam. It's not going to be more than 10% of it, but it'll be more than 5% of it, I think. So I think 45 minutes will be enough for our purposes. Here are the topics that are included. As discussed in the last section, the topics are addressed in the blueprints as either being core or advanced or fellow, of which there's no fellow discussions in the hemostasis and thrombosis section. We'll cover both of these, but with greater attention to the core topics. But we're going to go in a slightly different order just because I'm going to provide a little bit of physiology review. We'll start with disorders of primary hemostasis, so von Willebrand factor platelets, move to secondary hemostasis, focusing mainly on factor deficiencies and inhibitors. We'll cover thrombophilia with special attention to the acquired thrombophilia like HIT, TMAs, antiphospholipid syndrome. And then we'll finally cover the basics of anticoagulation monitoring with emphasis especially on the heparinoids and warfarin. And then I'll try to mix some active recall in throughout. So starting with physiology review. Primary hemostasis is, of course, the first response to vascular injury, right? The major players are going to be platelets and von Willebrand factor, as well as the local endothelial cells. Now, the goal of primary hemostasis is to form basically a weak platelet plug. It's structurally weak. It's better than nothing, but its main purpose is to serve as the nidus for the coagulation cascade to form a mature clot through secondary hemostasis. I mentioned endothelial cells, but we will not be discussing endotheliopathies because there is no decent laboratory assay to assess endothelial function. The closest thing that we have is the bleeding time. This is a primitive, poorly reproducible assay where you lance the patient and you measure the time to stop by blotting the injury every 15, 30 seconds. It performs terribly, but technically it does constitute an in vivo hemostasis assay, and therefore it is sensitive to endothelial dysfunction. So the only takeaway for you about the bleeding time is that in a patient with a history of bleeding, if all other testing is normal, then I guess a prolonged bleeding time could suggest a possible endothelial contribution, but I do not recommend you ever perform or offer this assay. Now, von Willebrand factor we can test. As a review, von Willebrand factor is a protein secreted as large multimers. It is synthesized in endothelial cells where it is stored in the Weibel Palade bodies, as well as in megakaryocytes where it gets packaged into platelet alpha granules. Now, when it's first secreted into the from the endothelium, it is released in so-called ultra-large von Willebrand multimers, which have to be cleaved by the matrix metalloproteinase ADAM-TS13 into its physiologic, merely kind of large multimers. You should know that von Willebrand factor contains binding domains for platelets via the GP1B receptor, for collagen, and for factor VIII. And in particular, almost all factor VIII is bound to von Willebrand factor. So the role of von Willebrand factor is to bind collagen that is exposed at the site of injury. The multimer is going to unfurl under the shear force of flowing blood going past, which will expose the sticky platelet binding A1 domains. That shear force is essential for von Willebrand factor activation, and so the larger a multimer is, the more sensitive it is to those shear forces. So the largest molecular weight multimers are going to be the most physiologically active. Now, this interaction is very important in fast-flowing arterial circulation, where although platelets do have their own collagen binding receptors like GP1-2 complex, GP6 complex, in rapid arterial circulation, they're unable to bind effectively and they need von Willebrand factor as a bridge. Now, von Willebrand disease, of course, will be a failure of von Willebrand factor function. It is the most common inherited bleeding disorder among all races and demographics. We'll go into the details on the different types, but just as an overview, understand that type 1 is a quantitative deficiency of normal von Willebrand factor. Type 2 is a qualitative abnormality in von Willebrand factor function, and type 3, of course, is a complete absence of the protein. So some key gems to remember about von Willebrand testing is that von Willebrand factor and factor VIII are notorious acute phase reactants. You shouldn't try testing in patients for diagnosis because they may have transiently high levels that can take them above the diagnostic cutoff, which would be a level of 30% with no history of significant bleeding and 50% with a history of clinically significant bleeding. Also, blood group O patients, just as some trivia, also have slightly lower circulating von Willebrand factor levels, which relates to increased clearance of the protein based on very different glycosylation patterns. So here are the subtypes of von Willebrand disease you should know. We'll get through it. Each row is a type, and each column is a different test that we can use to distinguish the types. So on the left here is the von Willebrand antigen level, how much of the protein is present. And the next is activity. There are many different possible activity assays, functional antibody testing, recombinant GP1B binding. We're going to simplify all of those as activity broadly. So the ratio is going to refer to the ratio of antigen to activity, very important. We'll come back to multimers, but also note that factor VIII binding activity, or at least a global factor VIII level, is also key in von Willebrand disease testing. So starting with type 1. In type 1, you have a decrease of normal von Willebrand factor. The antigen is decreased, but so is the activity, right? There's less of the protein for those functional assays, so the activity is decreased. What is key is that the ratio is normal, or at least greater than 0.7. These decreases are in proportion to each other. So in type 1, patients generally do respond to DDAVP, arginine vasopressin. You'll probably recall this is a drug that promotes secretion of von Willebrand factor from the Weibel-Palade bodies. An exception to this response would be in type 1C or Vicenza. In type 1C, the von Willebrand factor is low because of abnormally fast clearance. So DDAVP would be less effective in those patients. They would just clear it too quickly. And also the diagnostic feature in 1C is going to be a high amount of the von Willebrand factor propeptide, which is co-secreted with von Willebrand factor. In the type 2s, the ratio is now abnormally decreased. So the ratio is decreased in type 2. The amount of von Willebrand factor may be low, oftentimes it is, but the activity level should be disproportionately low. The next step, according to classic text, is to perform multimeric analysis. You do gel electrophoresis, and you assess if those largest multimers are retained or lost. Remember, the largest multimers tend to be the most functional. Now, if those multimers are lost, you're dealing with either a type 2A or a 2B von Willebrand disease, most of the time a 2A. 2A is defined by a loss of those multimers without meeting the specific diagnostic criteria for 2B. So it's sort of a junky category, and it can implicate many different mutations. I'll also point out that one flavor of the acquired von Willebrand syndrome, note that phrasing, syndrome is the term that we use for acquired von Willebrand disorders, whereas disease is reserved for congenital. So the most common pattern for acquired von Willebrand syndrome is going to be in conditions of very high blood shear forces, for example, in critical aortic stenosis, where as the von Willebrand factor goes through the aortic, past the cusps or leaflets, the shear forces actually cause spontaneous activation of those large multimers, causing them to fall out of solution, and it can, and in that respect, it can resemble a type 2A. There are other patterns of acquired von Willebrand syndrome, but I think for boards, this is probably the main one you should know. Now, 2B von Willebrand disease is much more specific. In 2B, there is a gain of function mutation that results in increased platelet von Willebrand interactions. A little counterintuitive, but rather than actually causing clotting because of that gain of function, those platelet von Willebrand complexes are pulled out of circulation, resulting in loss of the large molecular weight multimers, but also presenting with thrombocytopenia. They have low platelet counts. Now, you would definitely not want to give these patients DDAVP because more release of that abnormal overactive von Willebrand factor will in turn worsen that thrombocytopenia. Now, whenever we discuss 2B, you also have to consider the so-called platelet type von Willebrand disease. In platelet type, there's a gain of function mutation, but now it's in the platelet GP1B receptor, right? The result is the same. It's the same interaction, and they present identically, but in 2B, the mutation is in von Willebrand factor, and in platelet type, it's on the platelet GP1B complex. Now, both of these disorders confer high sensitivity to ristocetin, and a diagnostic test to confirm either 2B or platelet type is going to be the low-dose ristocetin-induced platelet aggregation test. We'll come right back to that. If your multimer analysis is normal, then and you have a low ratio, then you are probably dealing with type 2N. So again, ratio is low, it's type 2. Your multimers are normal. You're looking at 2M or 2N. Now, 2M is kind of a junk drawer category. Again, it comprises many different mutations, but in contrast, 2N is a very specific disorder that's a little bit of an oddball. In 2N, the mutation is in the factor VIII binding sites. Remember, 98% of factor VIII is bound to von Willebrand factor, and without it, it is cleared very, very quickly. So these patients will present with very low factor VIII levels, and they may often not have distinctive abnormalities of von Willebrand antigen or function otherwise. So in that respect, it'll look just like hemophilia A, but the key difference being that in von Willebrand 2N, this is transmitted in an autosomal fashion, right? Hemophilia A is sex-linked recessive. If you see a case that looks like hemophilia A, but there's a family history of both affected men and women, think instead about von Willebrand disease, which is also overall more common. Okay, so that's von Willebrand factor. As mentioned, its job is to grab platelets at the site of injury. Those platelets, upon activation, are going to undergo shape changes. They'll dump their granules, and they will express surface activation markers, negatively charged phospholipids, 2B3A, etc., to start secondary hemostasis. Now, these platelets normally circulate for a bit over a week. About a third of them are marginated out into the splenic and reticular endothelial spaces. Structurally, please recall that platelets have both alpha granules and dense granules. Alpha granules are visible under light microscopy, and they contain mostly proteinaceous substances, von Willebrand factor, factors 8 and 5, fibrinogen, platelet factor 4, things like that. Whereas the dense granules, they require electron microscopy to identify, and they contain mostly small ions like calcium, ADP, small molecules. A mnemonic that I use is that the alpha granules contain the largest molecules. Now, for platelet testing, we can look at abnormalities of platelet number or of platelet function. For number, it's pretty straightforward. We do a platelet count via the Coulter method using a CBC analyzer. I'm going to poll the audience, but in the interest of time, I'm not going to wait for a response. What condition can present with spuriously low platelet counts? Maybe, for example, with platelet clumping on peripheral smear. This should ring a bell for pseudo-thrombocytopenia. When collected into a standard lavender top, the EDTA anticoagulant can alter the GP2B3A complex, resulting in apparently an antibody-mediated aggregation. The way to avoid this is to just collect the sample into a blue top, which uses citrate, and then you can run that in the CBC analyzer. Okay, next question, what can cause spuriously high platelet counts via CBC? I haven't encountered this much in my clinical practice, but according to texts, any condition that can generate schistocytes, like a TMA, can present with a spuriously high platelet count because those red cell fragments may be platelet size and they can be read by the analyzer as platelets. That being said, I see a lot of TMAs and this rarely comes up, so I think modern CBC analyzers have software checks to prevent that. It may still sort of exist in the testing pedagogy, though. Okay, now for platelet function testing, we're going to spend most of our time on platelet aggregometry. As the name suggests, in platelet aggregometry, we are testing platelet function by looking for aggregation of platelets in response to different agonists, things like arachidonic acid or thromboxane, collagen, epinephrine. They should all induce platelet activation, right? So we measure this as an increase in light transmission through the platelet-rich sample, a platelet-rich plasma sample. It's a little bit counterintuitive, but when platelets are activated, they clump up and they fall out of solution, which actually increases light transmittance. Now, a couple of caveats about this. Patients have to have a normal-ish platelet count. You can't test platelet function if you can't collect platelets, right? And you also have to measure that increase in light transmission relative to a sample of the patient's platelet-poor plasma. If you've been in the blood bank, you've probably noticed that plasma color can be variable. Everyone's plasma is a different color. So when you do this testing, you actually need to optically blank against that patient's platelet-poor plasma sample. Now, what we're looking at is, in this graph, is the increase in light transmittance over time after adding different concentrations of agonists. The aggregation response is often described as biphasic. For the purpose of boards, we can just simplify it and treat it as a binary yes or no for aggregation. These are the patterns, and I really do recommend learning these. Boards love these. So first in the top row is going to be the normal expected response. Agonists like epinephrine, ADP, arachidonic acid, these things will induce platelet aggregation. You'll also see that one of the agonists is something called ristocetin, right? Ristocetin is an antibiotic that was found to induce platelet activation via von Willebrand factor activation. It has not been used as an antibiotic in decades because it precipitates severe thrombocytopenia. But you should know that it's still used in coagulation testing, and in particular, it can induce platelet activation, but only at moderate to high doses. The normal response is actually negative with so-called low-dose ristocetin, which were arbitrarily designated. Okay, the first two patterns to learn should be fairly intuitive. They're the drug patterns. If a patient is taking aspirin, aspirin inhibits cyclooxygenase, right? So they can't convert arachidonic acid into the activating molecule thromboxane A2. So patients with the aspirin-like defect do not respond to arachidonic acid, right? Meanwhile, the P2A12 inhibitors, these are drugs in the thienopyridine class like Plavix or ticagrelor. These block ADP signaling, so of course, patients taking these drugs don't respond to ADP. Straightforward. Glanzmann's thrombasthenia. You should know this one. In Glanzmann's thrombasthenia, there is a loss of platelet GP2B3A complex. This is the most important surface effector of platelets because it's what binds fibrinogen to form the primary platelet plug. And as such, Glanzmann's is the most severe qualitative platelet abnormality. And you tend to see failure of these platelets to activate in response to anything except for high-dose ristocetin. It's the only functional agonist. The opposite pattern is seen in Bernard-Soulier disorder. In Bernard-Soulier, now there's a loss of the platelet GP1B receptor, right? That's what binds von Willebrand factor. And as a result, ristocetin, even at high concentrations, will not induce platelet activation. Makes sense, right? Ristocetin activates von Willebrand factor, but then von Willebrand factor's main receptor on the platelets is non-functional. So in Glanzmann's, ristocetin is the only effective agonist, and in Bernard-Soulier, it's the only ineffective agonist. I would say ristocetin is also ineffective in most von Willebrand diseases, which makes sense, right? Again, failure of von Willebrand factor. The exception to that, however, will be type 2B. In type 2B, again, remember, there is a gain of function mutation in von Willebrand factor platelet GP1B interactions. And as a result, even very low doses of ristocetin are enough to induce platelet activation. This is that low-dose ristocetin-induced platelet activation study that we alluded to earlier, and this is one of the diagnostic features in 2B. You would also see it in platelet type, though I don't have it on my graph here. So let's review what we just talked about. What type of von Willebrand disease could present with preserved multimers and, with a decreased antigen activity ratio, but preserved multimers and a normal factor 8. I see that you guys are putting responses in chat, but I'm not stopping to look. I apologize. This is type 2M. Remember, if the ratio is decreased, you're dealing with a type 2. If the multimers are then preserved, then it's not 2A or 2B. Multimers are lost in 2A or 2B. So multimers are preserved. This is 2M or 2N. 2N specifically is an abnormality of factor 8 binding. So this is not that. This is 2M by process of elimination. What platelet disorder presents with loss of response to all agonists except for ristocetin? Just discussed it, just showed you guys, nothing works except ristocetin. That's Glanzmann's thrombasthenia. Very severe abnormality, and it shows the opposite pattern as Bernard-Soulier and the non-2B von Willebrand disease. Speaking of which, how would you distinguish Bernard-Soulier from von Willebrand disease on this basis? The easiest method is to do a peripheral smear. Remember that in Bernard-Soulier, there is a preponderance of giant platelets. These are platelets that are as large or are larger than the red cells. You could also just do von Willebrand disease testing, of course. All right. I'm just going to throw one slide at you about platelet function assays besides platelet aggregometry. The most common, simple benchtop assays for platelet function, mostly used for monitoring drug effects, are going to be the PFA 100 and the Verify Now. In the PFA 100, what you're doing is you're loading a whole blood sample onto this cartridge. And on this cartridge, there's a tiny, tiny aperture in a membrane. That membrane is embedded with collagen and some sort of an agonist, either epinephrine or ADP. You measure the time for the aperture to close when you push whole blood across it. Now, most platelet functional disorders, Glanzmann's, Bernard-Soulier, all these things, are going to cause both of these two cartridges to have very prolonged closure times, but maybe the most testworthy is going to be the aspirin lesion pattern. In patients who are on aspirin, the ADP channel is unaffected, while the epinephrine channel takes longer to close. This is not super intuitive. I don't have a mnemonic for you, and I constantly have to look this up myself, but ADP channel is unaffected by aspirin, and hopefully you guys can get that to stick. Now, the Verify Now is a particle agglutination assay. This is mostly going to be used for measuring platelet response to ADP receptor activations. There's also an aspirin cartridge available, but much more typically it's used for P2Y12 inhibitor function. So you're sort of looking for the effect of the thienopyridines like Plavix, ticagrelor, cangrelor, things like that. And you should ideally always get a baseline on these patients before starting thienopyridines to make sure there's not an underlying platelet abnormality. But I think you and I all know that that rarely ever happens. Okay. So back to quantitative abnormalities. I just want to shout out a couple of thrombocytopenic disorders. ITP, or immune thrombocytopenic purpura, results from autoantibodies to some kind of platelet antigen. Usually it's something very high frequency and common like the GP2B3A complex or the GP1B complex. It is a diagnosis of exclusion. There are platelet antibody tests, but they usually don't perform that well for diagnosing ITP. It is treated with immunosuppression, steroids, and maybe splenectomy. You do not transfuse platelets to a patient with ITP. It is a waste. You may as well chuck those in the trash. They do not survive even one pass of circulation. Don't do it. Now, PTP, or post-transfusion purpura, this is more of a blood bank topic. It's one of the delayed transfusion reactions, but I want to mention it here because it involves alloantibodies to a platelet antigen. In Caucasian patients, we're almost always talking about HPA-1a. These antibodies will end up knocking out the donor platelets, but interestingly in PTP, there is also bystander loss of recipient platelets. And so these patients present with a decrease in their platelet count after transfusion. They can actually often have very serious bleeding complications. It tends to be quite severe. Now, HPA-1a antibodies are also implicated in platelet refractoriness not related to HLA. Just stop that for a second. Platelet refractoriness most of the time is non-immune. In the cases that are immune, usually it's HLA antibodies. And then the small subset of cases that are not HLA related, then oftentimes you're dealing with an HPA antibody, most often HPA-1a. And then it's also implicated in the condition that's known as fetal or neonatal alloimmune thrombocytopenia. Think about this as HDFN, but for platelets. You have maternal platelet antibodies. They go into fetal circulation. They knock out fetal platelets and can cause severe fetal thrombocytopenia, and sometimes it can manifest with bleeds. Okay, rapid fire. Identify the platelet disorders. Number 1, dysfunctional platelets, oculocutaneous albinism, immunodeficiency, and a peripheral neuropathy, plus these really funky looking large granules and neutrophils. That is going to be Chediak-Higashi, resulting from mutations in lysosomal trafficking. Now, if you see platelet dysfunction, oculocutaneous albinism, but not immunodeficiency, but instead pulmonary fibrosis, maybe, for example, in a Puerto Rican patient, then maybe you should think instead about Hermansky-Pudlak syndrome. These patients usually need lung transplants because of the pulmonary fibrosis. All right, an X-linked triad of thrombocytopenia, eczema, and immunodeficiency should ring a bell for the Wiskott-Aldrich syndrome. I see chat firing up there. That should be a pretty clear one. And then this one you may not have seen, a disorder that presents with a failure of the scramblase. This is a protein that is involved in flipping phospholipids between membrane leaflets. And so this is a failure of expression of the negatively charged phosphatidylserine on the platelet surface. That is known as Scott syndrome. That one's probably a deeper cut. And then finally, what are these? I just showed you that image. Those are the giant platelets seen robustly in Bernard-Soulier. In Bernard-Soulier, you have fields and fields and fields of giant platelets. You can also see them in myelodysplastic syndromes, but they're much more occasional then. Okay, done with primary hemostasis. Let's go to secondary hemostasis. I think I have to increase my pace a little bit here. Now we have a platelet plug. We want to generate fibrin. The fibrin is going to result from the coagulation cascade converging onto thrombin. Thrombin will polymerize fibrinogen into fibrin, and then those fibrin monomers are going to be cross-linked by factor 13 for maturation. And this entire process needs to be kept localized only to the site of injury. You do not want these fibrin clots spreading all throughout your entire vessel. So here's an oversimplification of the coagulation cascade. I'm not drawing it out for you. Best of luck. Remember that this is not what actually occurs in vivo. This really reflects how we assay the cascade in lab with things like the PT study and the PTT study, right? The intrinsic and extrinsic pathways both converge on the common pathway. Hopefully you can construct this, and if not, just remember what factors are part of each pathway. On that note, the coagulation factors, these are all freely circulating factors in plasma, not serum, right? Serum is a clotted sample. Plasma contains coagulation factors, serum does not. Now, these factors are almost all made by the liver with the main exception of factor 8. Fibrinogen is the main building block of clots, so it's present in highest concentration. Now, deficiency of coagulation factors will generally cause abnormal bleeding, but we have a physiologic reserve such that clotting times really only start to prolong once your factor levels start dropping below 30%. Also, one of these factors does not result in any bleeding at all when deficient. If anyone knows this, great. If not, it's factor 12. Factor 12 is at the very top of the intrinsic pathway, and it actually plays a very insignificant role in clotting in vivo. Fun test-worthy one. I normally like to harp on the significance of different structures and the coagulation factors. I'll spare you. We'll just focus in on the vitamin K deficient, dependent factors. So vitamin K is needed to synthesize the glutamines that are expressed in the factors 2, 7, 9, and 10. You guys know this from med school. Vitamin K deficiency, such as in poor diet, malabsorption, newborn status, or more commonly, patients who are on warfarin, will result in a deficiency of those 4 coagulation factors. It'll also result in deficiency of the natural anticoagulants protein C and S. We'll come back to those. So as mentioned, if we use tests like the PT and the PTT to assess the coagulation cascade, what is this test? What does this actually constitute? So we collect a whole blood sample into citrate. Since we're on the topic of different colored tops, the blue tops contain sodium citrate. And what you must understand is that the amount of anticoagulant in a blue top is very specifically measured. In a blue top has to be filled up to a very precise fill line in order to ensure that magical 3.2% citrate concentration, in contrast to most other colored tops. Now, we incubate the plasma with different activators, and these activators are going to define each of the different coagulation assays. Then we restore calcium as sort of the starting gun, and we measure the time for a clot to form. The clot forms once you've made thrombin, and thrombin begins polymerizing fibrinogen. So if that clotting time is prolonged, that could be due to a deficiency of coagulation factors, or it could be due to an inhibitor that impedes that cascade towards thrombin generation. All right, let's go through a pretty commonplace example. Here's an 85-year-old guy, new skin bruising and hematuria. He has a PT study that is normal and a PTT study which is prolonged. Okay, so in this example, clearly there is something wrong in the intrinsic pathway, right? PTT is prolonged. If it were the extrinsic or the common pathway, then the PT would be affected as well. Now, how can we tell if this is the result of a deficiency or an inhibitor? We do a mixing study, which we'll cover on the next slide. If there is a deficiency, what are the possible factors that could be implicated? We said intrinsic pathway, right? So that could be 8, 9, or 11. And factor 12 deficiency could present with these labs, but again, remember, factor 12 deficiency not associated with real bleeding events, which this patient has. So mixing studies work by exploiting the fact that you only need around 30 to 40% of normal coagulation factor activity, right? To hemostasis normally anyways. If I take normal plasma and I mix it 1-to-1 with like nothing, just saline, I would still have 50% activity of all coagulation factors. PT and PTT would be still roughly normal. Now, if I mix a patient sample with normal plasma, I'm going to fix any coagulation factor deficiency that's present. The clotting time should correct, right? If it doesn't correct, that implies that there is a rapid inhibitor present. For example, let's say there's heparin in the sample. If I do a mix, that heparin will be diluted out twofold, but that's still enough to inhibit clot formation significantly. On the flip side, there are inhibitors which are known as time-dependent inhibitors. They don't work immediately after a mix. So if I have a mixing study that corrects, the next thing you should do is to then incubate that sample for 1 to 2 hours. This is going to allow the time-dependent inhibitor to exert its effects, and the clotting time will prolong substantially. There's probably only one example of those that you need to know, and that is going to be the factor VIII inhibitor. That's actually what's going on in our vignette. Factor VIII autoantibodies can be seen spontaneously in elderly patients, sometimes as a primary disorder, more often my experience secondary to a hematolymphoid disorder. Now, factor VIII is what's implicated in hemophilia A, so sometimes this is referred to as acquired hemophilia. The PTT is going to be prolonged while the PT is normal. The mix will correct initially, reflecting that factor VIII deficiency, but then it will disproportionately prolong after incubation, reflecting the time-dependent nature of the factor VIII inhibitor. When we think about coagulation factor inhibitors, we're usually thinking about anticoagulants like heparin or a DOAC, or antibodies like a lupus anticoagulant or like the factor VIII antibody I mentioned. A general concept I want you to understand, and this will be tricky, is that inhibitors cause something that's known as non-parallelism or non-linearity. Say you're doing a factor assay. You're trying to find out the amount of factor VIII in a patient sample using a PTT-based method, and you're comparing it to a reference curve with known factor VIII concentration. It's normal practice to run several different dilutions of patient sample and then multiply back by that dilution factor to determine what the amount of coagulation factor that is present. Generally speaking, across several dilutions, you should multiply back to find the same amount of coagulation factor that's present. It ends up looking linear on semi-log graph, and it'll be parallel to your reference curve. However, if you have an inhibitor present in your sample, what might happen is that as you do your first dilutions, you go from neat to 1-to-1 to 1-to-2. The clotting time doesn't get longer, even though the coagulation factors are getting more diluted. You're diluting out the inhibitor, so the clotting time may stay the same or it might actually get better. And so what happens is that on this segment of the curve, it's not going to be parallel to your reference curve. So that's called non-parallelism, or as taken by itself, non-linearity. If that sounded like completely unrelatable nonsense, that is okay. Factor assays are tricky. They merit a whole hour discussion on their own. Just remember that inhibitors cause non-parallelism or non-linearity. It's a good buzzword to have in your lexicon. Okay, here's a few associations you should know relating to specific factor deficiencies. So deficiencies of factor 8, 9, and 11 are going to constitute hemophilias A, B, and C, respectively. If you see factor 8 deficiency with an autosomal pattern, think instead of von Willebrand disease. And if the patient is elderly upon first presentation, think instead of acquired hemophilia, the factor 8 autoantibodies. Remember that hemophilia C is autosomal recessive, unlike A and B, which are X-linked recessive. And hemophilia C is really only seen in patients of Ashkenazi Jewish ancestry. Here's some oddball ones. Patients who have been exposed to topical thrombin gels, these are like surgical hemostatic agents, especially those of bovine origin. These patients can form antibodies against thrombin that will cross-react with their own prothrombin, so they can have low prothrombin levels. You can also see low prothrombin levels in a subset of patients with lupus anticoagulants, the so-called lupus anticoagulant hypoprothrombinemia syndrome. Now, factor 7 deficiency is super rare, like 1 in like a million or maybe a half million. What's a little more common is the condition known as factor 7 Padua. In factor 7 Padua, these patients' plasma, they don't react with conventional PT reagents. Most coagulation laboratories use a thromboplast that's based on rabbit brain, and just due to the fundamental differences between human and rabbit, these patients do not respond to it. You test them again using a human recombinant and it's normal, so it's mostly a laboratory abnormality. So that's factor 7 Padua. Maybe the most important one for me to point out here for like boards testing, just random trivia, is factor 10 deficiency. Very distinctive. You see an amyloidosis. Think of this as the amyloid fibrils actually adsorbing out the factor 10 protein. And then we've sort of covered factor 12 and the vitamin K deficiencies. So let's move on. Factor dosing is not something that I do in my clinical practice ever, but it loves to come up on PAF boards, go figure. It's easy enough. Let's just go through it. There are commercially available factor 8 and factor 9 concentrates. To replete these factors, you take the delta, basically the increment in the patient's factor activity level. Express that as an integer, not as a percentage. So if you want to kick someone's factor activity up 50%, you start with 50 IUs, not 0.5. Multiply that by the patient's body weight, and then if you're dealing with factor 8, there's a fudge factor where you divide by half, because factor 8 has much greater in vivo recovery than factor 9. That's it. That's the whole formula. If you, just as an example, if you want to restore 100% of factor activity in a totally deficient 70 kilogram patient, take 100 IUs, multiply by 70, and because this one's factor 8, not factor 9, fudge factor divided by half, and that's your total factor 8 dose to replenish. Here's some more random trivia that I don't personally find helpful, but could come up. Which coagulation factor has the shortest half-life in vivo? I'll remind you from blood bank that factor 5 and 8 have the shortest half-lives ex vivo. They fall apart at room temperature in bags and such, but in the body, factor 7 is the shortest lived in circulation. The longest lived in circulation would be factor 13, which has a week-long half-life. Now, the factor present in high concentration, I've already told you, was factor 1, or fibrinogen, while the lowest concentration factor is factor 8, or I guess tissue factor, if you want to argue that it be lumped in with the other coagulation factors. And then finally, which factor deficiency prolongs neither the PT nor the PTT? It's not 12. I'm done with 12. That's factor 13. Remember that factor 13 works downstream of thrombin. So PT and PTT, the timer stops once you start getting that immature clot. Factor 13 works to mature the clot. So PT and PT are insensitive to factor 13 deficiency. Let's talk about that a little bit more. Fibrinogen is secreted as these floating monomers that consist of a central globular E domain and 2 terminal globular D domains. When cleaved by thrombin, the monomers will spontaneously polymerize like overlapping bricks on a wall. And then factor 13 is going to work to cross-link those adjacent D domains to strengthen and mature the clot. All of this has to happen in a very regulated fashion. It should only be at the site of injury. This is handled using at least 3 control axes. First of all, antithrombin. This is a protease inhibitor that blocks at least antithrombin, thrombin, as its name would suggest, as well as activated 10A. And its activity is potentiated by negatively charged molecules like heparin. The protein CNS system, this is a proteolytic system activated by thrombin, especially thrombin that's diffused away from the site of injury, to feedback negatively and degrade factors 5 and 8. Remember that protein C and protein S are both vitamin K dependent, and I'm just going to skip over TFPI for time. Last physiologic concept to review is fibrinolysis. Once a mature clot has formed, the wound will eventually need to heal. The clot will eventually have to be dissolved and broken down, right? This is handled by plasmin. Plasmin is the main effector. It is activated from plasminogen, usually by the very intuitively named tissue plasminogen activator, TPA. This is mostly from endothelial cells. That plasmin will go to break down the fibrin clot, furnishing fibrin degradation products such as the D-dimer. There's a lot of regulators of fibrinolysis. These are molecules like Pi1, alpha-2 antiplasmin, TAFI. These are deep in scope, and the testing for these molecules is very esoteric. I'm also going over time, so I guess just try to remember that these molecules suppress fibrinolysis, and therefore failure of Pi1, alpha-2 antiplasmin, TAFI will result in a bleeding phenotype, right? Because then fibrinolysis will predominate, and that is pro-bleeding. So the D-dimer is very commonly used. If a patient has an elevated D-dimer, what does that mean? Somewhere in the body, a clot has formed, it was cross-linked and matured, and it was at least partially broken down. This is an immunoassay, usually a latex particle agglutination assay, and it's very sensitive for thrombotic conditions, but it is non-specific, mostly used, for example, to rule out DVTs or PEs. The main fibrinolytic disorder that you need to recognize is hyperfibrinolysis. This is overactivation of the fibrinolytic system. Plasmin is very stupid. In addition to lysing mature clots, it will happily shred up soluble fibrinogen, which is bad. That impairs helpful clot formation. It's never good. The result will be a severe refractory bleeding phenotype. I tend to see this in blunt trauma patients, and you need to treat it immediately by giving antifibrinolytic drugs, in particular tranexamic acid, or TXA, or aminocaproic acid, or Amicar. You probably learned about those in med school as an antidote to systemic TPA administration. The difficulty with this disorder is in recognizing it. How do you know that your heavily bleeding patient is bleeding because of fibrinolytic activation? The old-timey test is something called the euglobulin clot lysis. It takes hours. It is almost never available locally. So in practice, most providers are actually going to use viscoelastic testing to identify hyperfibrinolysis. Let's take a brief diversion. Viscoelastic testing is a relatively new method, at least it's popular now, that assays whole blood, not just spun citrated plasma. By evaluating clot strength over real time, viscoelastic tests like the TAG or the ROTEM will give you a snapshot to multiple contributors to hemostasis, coagulation factors, platelets, fibrinogen, fibrinolysis. You, audience, need to be able to interpret these wave trace morphologies for CP boards. Here is a normal example of a wave trace. It's sort of glass-shaped. I'm going to use TEG language here, but the stem, or the R time, this is the time it takes for the clot to initially form. During this phase, you've got coagulation factors all cascading onto each other, and so prolongation of this time may reflect factor deficiencies or factor inhibitors. Now, the height of the wave trace reflects the clot's strength. That's mostly driven by platelets and fibrinogen. And you can also evaluate for any weakening of that clot over time, which would reflect abnormal hyperfibrinolysis. Clots do need to break down eventually, but you should not be seeing clot breakdown within the 1 hour span of a viscoelastic test. So here are 3 abnormal traces. What's wrong and what should the provider do to correct the abnormality? In C, the stem is long. The clot is taking too long to form. This could be due to factor deficiencies or inhibitors. So, first check to ensure the patient's not on heparin or bivalirudin or something, but then also give plasma to replete the deficient factors. In D, the trace forms in the normal expected amount of time, but it's weak. It's very narrow. So this is going to be a deficiency of either platelets or fibrinogen. So you could transfuse those to correct it. And then finally, E, this is the scary trace. The clot forms and then it immediately almost totally weakens and dissolves. That's hyperfibrinolysis, and that should trigger you to give something like TXA. Okay, we're on to thrombophilia now, and let's start with the heritable clotting disorders. First, I want you to understand when this testing is indicated. I do see a lot of chat messages. Seriously, verbally interrupt me if I'm missing something huge here. First thing I want you to understand is when thrombophilia testing is indicated. When should you search for a clotting disorder? If a patient develops a clot and either the clot is recurrent, it's in a young patient, it's in a weird location, and especially if it's unprovoked, it needs to be unprovoked, then you should consider thrombophilia testing. When you should not be testing is immediately upon first presentation of that clot. This is a tendency I see in inpatient providers all the time. They start chasing clotting disorders while the patient is still being admitted or even actively anticoagulated for their DVT. Don't do that. You cannot get good diagnostic results. The patient's factor levels may be depleted from consumption, or they may be spiked up from acute phase. Don't do it. Save thrombophilia testing for the outpatient setting. The most common thrombophilia by far is factor V Leiden, or at least inherited thrombophilia. This is usually caused by a specific point mutation that induces resistance of the factor V protein to degradation by the protein CNS systems. In Caucasians, it's very common, about 5% of Caucasian patients being heterozygous for the disorder. Now, the risk incurred by heterozygosity is mild to moderate, but homozygosity confers a significant risk. The test is a genetic assay for the point mutation, but we usually first screen by doing what's called the activated protein C resistance test. Basically, we run a PTT and then we spike the patient sample with activated protein C. That should break down factor V and VIII. And so the clot time should prolong when we do that. If the patient sample does not prolong, if it's completely indifferent to activated protein C, it's resistant, the screen is positive, and then we reflex to genetic testing. Now, the prothrombin G2210A mutation, this is a promoter site mutation. It results in mild increases in factor II levels. The risk conferred by it is also rather mild, and it's also a genetic assay. Blah. Protein CNS deficiencies might be more test-worthy. These can be acquired or inherited. Remember that protein CNS are natural anticoagulants, so if you're deficient in those, you end up with a pro-clotting phenotype. One very specific and testable manifestation is the horrible condition referred to as purpura fulminans, usually seen with homozygous protein C deficiency. The clot risk skyrockets, and they manifest with these ecchymotic and necrotic skin lesions, often in infancy. You can also see purpura fulminans with protein S deficiency too, but C is more common. And also remember that about 60% of protein S is bound it's an inactive bound form stuck to the C4 complement binding protein. And then lastly, antithrombin deficiency can be congenital, but it can also be seen in protein wasting nephropathies and often confers a very strong clot risk. Ooh, okay, we're doing out of time. We're actually over, but still have about 9 slides of content. I'll try to go quick. HITS, or heparin-induced thrombocytopenia, is a feared complication of heparin therapy. There is formation of this platelet PF4 and heparin, some polyanion neoepitope. The antibodies are expressed, the immune complex is deposited on the platelets, causing them to activate. Those patients will have a low platelet count, but paradoxically, they're very prothrombotic, and they usually announce themselves with a new thrombus somewhere. The treatment is to, first of all, stop heparin right away. But also, don't forget, put the patient on an alternative anticoagulant, usually a DTI like argatroban or bivalirudin. HIT diagnosis should start with preclinical risk assessment. That would be the 4T score. I'm skipping over it for time. The screening diagnostic test is going to be the PF4 ELISA. This is a very, very sensitive assay, and the stronger the ELISA is positive, the higher its positive predictive value. And the confirmatory test will probably be listed as the serotonin release assay. There are newer confirmatory tests like p-selectin flow cytometry, but for boards, probably just remember the serotonin release assay. TMAs, we'll just do one, which is TTP. TTP is caused by a deficiency of ADAMTS13, right? The protein A. And the reason this results is usually because of an acquired autoantibody that, in my experience, primarily occurs in female patients of African American descent. There's also an inherited ADAMTS13 deficiency that's called Upshaw-Schulman syndrome. Without the effect of ADAMTS13, you get von Willebrand factors secreted as those enormous ultra-large multimers, and they're so big that they just spontaneously activate from the regular shear forces of circulation. They activate platelets, thrombocytopenia results. Our diagnostic test will therefore be the ADAMTS13 level, and the treatment is, of course, plasma exchange, for which you should give full FFP repletion to replace the deficient ADAMTS13 protein, as well as to remove the antibody. Do not transfuse these patients' platelets either, because they are prothrombotic, adding fuel to the fire, as the old expression goes. Don't transfuse HIT, don't transfuse TTP, and yeah, don't transfuse ITP either. And the last thrombophilia, my favorite, is antiphospholipid syndrome. In antiphospholipid syndrome, you have autoantibodies against phospholipids and associated antigens. This results in both venous and arterial thrombi, and pregnancy loss is a very classic association. However, clotting tests like the PTT tend to be prolonged because of how little phospholipid is available for use in those assays normally. That prolongation is referred to as the lupus anticoagulant, which is the name that confuses everybody. Yes, it's associated with autoimmune disorders, but the Venn diagram is not a complete overlap. Okay, so to diagnose APLS, you need both clinical evidence of thromboses and laboratory evidence, which is either going to be the lupus anticoagulant, which is going to be prolongation in usually a PTT or DRVVT-based test that improves when you spike more phospholipid in. You end up neutralizing the antibody. That's a positive lupus anticoagulant test. Or you can look for antibodies against cardiolipin or beta-2 glycoprotein 1 antigens, IgG or IgM only, please. And then very testable is the fact that you have to test these patients twice, at least 12 weeks apart. This is because APLS is a lifelong diagnosis requiring lifelong anticoagulation, and you can see positive results occurring very transiently in many patients, and you shouldn't diagnose them if they then test negative 12 weeks later. Test twice. I'm going to skip over this slide because it's pretty low yield. Let's get over to anticoagulation. 4 slides, then I'm giving you a break. I shall cut it down to 3. Heparin works by potentiating antithrombin. Remember that fractionated, low molecular weight heparin directs antithrombin more against activated factor 10, and fondaparinux even more so, to the extent that there is like no thrombin inhibition at all. Now, the gold standard method to detect heparin effect is something that's called the anti-10A study. Basically, sorry. We got someone unmuted, by the way, just a heads up. So the idea is we're taking reagent 10A and we're measuring the rate of formation of a chromogenic product. If a patient sample has a 10A inhibitor, it's going to slow the production of that chromogenic product, and we can compare to a reference curve. So you can use this to monitor DOACs like rivaroxaban and apixaban because they inhibit XA 10A, right? But it's the standard for heparin. That being said, you guys probably all know that clinical teams tend to use the PTT instead to monitor heparin. What is the antidote for heparin overdose? You guys should know that. That's protamine sulfate. So heparin's therapeutic range, and I would remember this, is 0.3 to 0.7 IUs per ml. So why then, what's the deal with the PTT? PTTs are cheaper and faster than anti-10As, and they also correlate with them quite well. Coagulation laboratories should routinely be establishing PTT ranges that correspond to that therapeutic 0.3 to 0.7 IU heparin range. This is what the clinical teams are going to use to follow heparin anticoagulants and to titrate dosing. However, this only works if there are no other sources of PTT prolongation. If I have a patient who has a baseline factor deficiency and their PTT is like 50 seconds before starting heparin, then that 60 to 95 second window is not appropriate. It will not really reflect a therapeutic range of heparin. Same goes if you have another inhibitor like a lupus anticoagulant or like they're being bridged from another anticoagulant, things like that. The main side effect of heparin, as with anticoagulation, is bleeding, but I guess it comes over and over again in boards review, is that it does cause osteoclast activation. So I guess remember that heparin is associated with osteoporosis, I guess. And then we'll make this our last slide. That's heparin. Now, warfarin. Warfarin inhibits the V-core complex, which is involved in cycling of vitamin K. Vitamin K exists in different redox states that are needed to make those glutamines. So blocking it will constitute a functional vitamin K deficiency. This is going to result in deficiencies of 2, 7, 9, and 10, as we discussed, but also protein CNS. And protein CNS actually falls first, which means that there's a transient prothrombotic state that you can encounter when you start warfarin just natively. You've probably heard the term warfarin-induced skin necrosis. So when initiating warfarin, it is standard to bridge with heparin or another anticoagulant. Monitoring of warfarin, as you know, is based on the PT-INR. Remember that different labs may have different thromboplastin reagents. A 12-second PT in my lab using Rabbit Brain might be different than the 13 seconds at Northwestern's using some other reagent. And so that affects result generalizability. Enter then the INR, or the International Normalized Ratio. This corrects for thromoplastin lot reagents by using a fudge factor called the ISI. So the INR is calculated as the ratio of the patient's prothrombin time compared to your local geometric, like normal donor mean, raised to the power of the ISI. The therapeutic target is generally going to be an INR of 2 to 3. I had some like rapid fire questions here. I think just in the interest of time, we should probably just go through those, and I can give you guys like 3 minutes of your break back. Leave that slide up for a second here if there's anything here that's not ringing a bell.
You should have asked them the questions. It was fantabulous. That was really a whirlwind tour through coagulation without getting clots or getting, fibrinolysis. This is really, really great. And I think even I learned the anti-10A with that little point to remember.
Yeah, a lot of coagulation testing can be fairly inscrutable, certainly to a general clinical audience, but even pathology trainees. So I wanted to try to spend a little bit of time to talk about how we do the testing while still focusing on the very boards. This is a boards review. I want to focus on those buzzworthy topics as well. Yeah,
perfect. Very nicely done. I'm sure there are probably some questions out there.
I see 86 unread chat messages, so I'll go through those over the next little bit.
Yeah, go through that. And for those, I think let's take about maybe a 10-minute break. I think that would not be bad. Is that okay with you, Dr. Trabzonlu? Can we start at 3:10?
Sure, of course.
Yeah. So let's do that. And I think, I think this for the day, we probably concluded, and for the 2 days, we probably concluded all CP topics. What we have now is GU, neuropath, and breast. And I don't know if Dr. Singh is going to be able to do any of the informatics, but if not, probably try to do that for next year between informatics and lab management. So again, let's come back at 3:10. And Dr. Carl, if you even want to go back through your question, that slide, and you want to question the audience, if someone's around, you could probably question them if they've not paid attention to the answer.
Sounds good. I'm going through, and it looks like we had a lot of just answering of responses or blush responses to the questions, and I'm going through these specific questions.
Sounds great. Thank you. All right, so it's 3:10 and we'll get you started. So good afternoon. For those who are still paying attention, pleasure to introduce Dr. Trabzonlu, again, one of my former residents who's done this course and currently faculty at U of I, and he's a fabulous GU pathologist and cytopathologist. And he is, like, all people like Dr. Carl, Dr. Trabzonlu are also fresh of taking boards. All this literature, everything is pretty fresh in their minds, and they are going to give their very unique perspectives on how to tackle this in the same pace that you've been going on for the past 2 days. So with that, Dr. Trabzonlu, you can go ahead and get started on GU.
Awesome. Thank you for the nice introduction, Dr. Viju. As a previous course taker, I'm not sure if I'm sharing the right screen. Am I?
Yeah, we don't see the full screen though. It says CPS board and the CPS. Yeah.
Okay. All right. Perfect.
There you are.
So hello everyone. My name is Dr. Trabzonlu. I'm also a previous sort of taker of this course, and I'm amazed that